Well, thanks to the panel for some really, really intriguing presentations. I really appreciate all the work that's been done. I was going to say that I wanted to start on the left-hand side because I know we're in DC and all the attention goes to the right. So we're going to start to the left, but apparently there's nobody at the left-hand side. So anybody who wants to run to the left-hand side and ask a question, you're going to get it first. But since we didn't have that, I still got the joke in. But go ahead and.
Yeah, actually, we are from our perspective, this is the left-hand side because you're facing the other way, right? So this is Greta Massetti from the CDC. So I think this is a fantastic session. Thank you to all of you, and I really enjoyed all the presentation. And the last presentation definitely touched on my question that's been in my mind, and that relates to, the potential discrepancy between what's recommended in guidelines versus what the best practices are, right? So as several of you mentioned, counseling, smoking cessation is part of recommendations in many, many guidelines. And yet when we're talking about, when several of you presented on trials about what works, what's being done as evidence-based for smoking cessation is not advising patients maybe you should quit. It is much more of an intensive intervention, right? So we know that in order to get smokers to quit smoking, it takes a lot more than advice. So can you talk a little bit about kind of how to fill that gap and go beyond just maybe you should consider not smoking anymore and getting to the more intensive interventions being able to be provided at all levels in smoking, in lung cancer screening?
That. To me, it comes down to identifying a clinical workflow and that being realistic about what are the resources that a screening site has and where different intensities of interventions can and should be offered. I think, I'm of the position that we don't know yet how many components, what's the dose we need that we can afford to be able to sort of optimize a quit rate. So for me, it comes down to thinking, I don't know, is it meds and counseling? Is it 3 sessions? Is it 4 sessions? So I'm advocating for something I would call kind of a scalable, adaptive model of tobacco treatment delivery that is based on a flexible notion of a workflow that you can always add on. But I'm not sure these sites can really, start with the Cadillac and be sustained. But, I think there's lots of opinions, and it's really an empirical question.
So my thought about that, I guess, was to take the cessation out of the site, right? So that's what telephone counseling is, to not rely on screening sites that I knew were already overworked and overburdened and trying to figure things out. And what already exists out there that we know works, and telephone counseling, as I mentioned, with older smokers is certainly one of them. But I think that once lung screening programs are really much more underway and able to take this on, that more of it could happen within the lung screening site. But I think that sort of reducing the burden on the lung screening sites was something that I was pretty interested in, and as well in the scalability of, because not every, even really big programs and really small programs won't have the same resources to devote to cessation, and so doing something that everybody can participate in, I think, is pretty important.
Yeah, I agree with Kate and Jamie. I think to add to that as well is that one of the issues is going to be the reimbursement, in that the way the guidelines are set and the reimbursements are set, the folks who are in the end going to be delivering the heart of the smoking cessation counseling, we don't have modes of paying them right now. So the work that we're doing also virtual deliveries, we're using tobacco counselors, we're working with this great navigation program in the community to bring folks in. But the issue remains that we're funding that through grants and through philanthropy. So I would hope over time that we're able to collect data showing the efficacy, effectiveness, and cost effectiveness of this work so that can change.
Just to be completely contrarian, we're taking a different approach in Kentucky because we really feel that we need to bring resources or training to our sites that we're working with because we're working with a lot of really low resource sites. And so one of the things that we have to offer and can do with some of our funding is to offer training and increase the number of certified tobacco treatment specialists that are available. And so one of the things that we're doing is we're offering opportunities for program coordinators to lung cancer screening program coordinators to pursue training as a certified tobacco treatment specialist. We have in Kentucky, I think at last count, there were four people who had completed the training in our entire state to be a certified tobacco treatment specialist. And so we feel like with this support and this funding, we can not only expand the smoking cessation and evidence-based tobacco treatment strategies in screening programs, but then that it will filter out even more broadly to other settings after that. Because remember, we're talking about low resource, somewhat lower volume screening programs, whereas we don't anticipate seeing the hundreds of patients going through these programs. So we can actually help diversify the options available by training the navigators to do high quality evidence-based tobacco treatment. And I raise this because I think that there are some differences and there's not a one-size-fits-all approach. This may not be possible. I remember Chris and I had a discussion on one of our calls as to burdening the lung cancer navigator with tobacco treatment at the same time that they're responsible for everything else may be too much. However, when you're in a low resource setting and a low training setting, providing that in a low volume setting, that tobacco treatment may be a very important part of their job. Because one of the things about working in rural healthcare is that these healthcare providers really see themselves as a broad healthcare provider, as opposed to just, they're not a specialist, they're an all-comer. We do, with our work with dentists and dental hygienists, they don't see themselves necessarily as just oral healthcare providers. That may be the only patient contact that person has all year or over the last 5 years, and so they really take that as a responsibility to do as much as they can in a broader domain. And so that's the justification that we've used to try to see how this type of a model would work in these lower resource, lower volume settings where there isn't a referral you can make to get high quality tobacco treatment. And so when you're the only game in town, let's do it as well as we can do it.
Joanna Stahms, Pennsylvania Department of Health. I might make a suggestion that you might think about looking throughout your organization to find out if there are already tobacco cessation programs being held in your organization through another department, such as your respiratory care department, or as an outpatient. I'm going to be talking about that a little bit tomorrow. And also, you might want to consider your respiratory therapists as an underutilized healthcare practitioner. They have a wealth of knowledge and are really trained to do and speak about that kind of work. And could be, utilized in situations that you're talking about in Kentucky. Most hospitals do have at least, one or two respiratory care practitioners on staff, and a lot of them are trained as CTTSs. So that might be something that you would want to utilize.
Some of them are site coordinators.
Right. So that might be somewhere you would want to go.
That's a good point.
So this question is a little bit for Elise, but perhaps any of you, and it's based on a comment that Denny Aberle from UCLA. It's based on a comment that Jamie made, which was that the smoking intervention itself will not stimulate smoking cessation. And when we,
The lung screening
oh,
itself.
what did I say?
You said smoking. The
I'm so
lung
sorry.
screening. So
Lung screening will not stimulate smoking cessation. The question for in the example of the NLST, clearly we couldn't put on a 50,000 participant screening trial without offering some guidance on smoking cessation. However, in the NLST, there was extreme pressure to enroll early so that we had long enough periods of follow-up to see outcomes. And that, in some ways, I think was a disincentive, because the concern was that if we were aggressive with patients about smoking cessation as they were enrolling into the trial, we would lose them. So I think the NLST is not the example for how we would implement smoking cessation into screening programs. We can do much better than that. And I think that the screening programs, certainly if we look at what Martin Tamamaji's more recent data has shown, we can actually use the screening result, perhaps even if it's negative, to motivate before they get screened, and then to try to reinforce when their screening result is communicated with them. You guys want to comment on that at all?
First, I just want to correct, I certainly don't mean that the screening has no impact. I think that we have not yet identified how to best harness those ingredients to drive cessation in this population. But I agree with you that there's a lot of encouraging, very promising work looking at personalizing screening results and piggybacking on existing resources. And I think that we are really in the infancy of beginning to know how to implement this, rather than saying this. I'm one of those people that believes there's a tremendous opportunity and really has the potential to teach us about how to engage populations in evidence-based tobacco treatment, rather than something that was done, that didn't work. I'm not saying that at all.
Okay.
So thanks. Right. So in the trial, you did give everyone a booklet, a referral booklet. Although the qualitative interviews, they didn't remember them. But
Right.
But that's the standard of care, Jenny. So that's important. You did do that. I think that this is often a fear, and it came up in the work that Jamie was showing with barriers. When I originally did my barrier scale with primary care physicians about smoking cessation interventions, that comes up that people are afraid that if they bring up the smoking cessation, which is like the elephant in the room, that it will scare off patients. And I believe that we really need to normalize smoking cessation, bring that into the conversations at the very beginning. We have a patient navigation intervention now going to the community, encouraging patients who fit the screening criteria to schedule an appointment with their primary care physician. And at that point, the smoking cessation conversations start. And then it should happen if the patient goes to the primary care physician for that shared decision-making encounter. And we should use all staff and leverage a team approach for when the screening is undergoing, whether it's a respiratory therapist and then afterwards when patients are getting the screening results. So I think if it's normalized and we really are very patient-centered in bringing it up with the patient and then giving them the opportunity to follow up with it when they need, we won't scare off anybody. But the concern is when we don't bring it up throughout that process, patients hear that as permission to continue their behavior.
Thanks.
I want to make one more point about one of the things that struck me most about Jamie O's data was the striking difference between in the latent class analysis was training. That was the single variable that seemed to differentiate a program that was doing it and not doing it, if I saw that correctly. And that I think that can address this perception that people will be sort of disenfranchised by asking them about their smoking. And if we do that in an empathic, motivational, interviewing kind of way, where instead of a "you gotta quit" kind of and a stigmatizing and badgering kind of a way, that if we can help our folks that are responsible for this be trained at the highest levels of evidence-based tobacco treatment, that we can get around that barrier and hopefully be doing a much better job of integrating this as a vital part of it. Because there's also some data that Elise was referring to, is that if we don't address it, they think it's weird. In certain situations that it's a little bit awkward that, and what kind of message does it send that we're so scared to talk about it that our patients are thinking this is strange that they didn't mention it at all. Now, strange is still better than badgering, but we can do better than strange.
I just wanted to add that when we accrued participants for the trial I presented, we were very explicit that you do not need to be ready to quit in order to participate. We want to meet you where you are. You do not have to set a quit date during the entire 6 sessions. And there were many people, as you could see, who we went through all 6 sessions and never set a quit date. And that was okay because the things that we talked about was you may not be ready right now, and we understand that. But what you're learning now may provide you with the skills and background that you need once you are ready. So I think that was really important, and that was partially how we were able to accrue people, 50% of whom reported that they were absolutely not ready to quit. But that's, I think, a really important message. I think it's, it goes to the issue with regard to stigma and really being inclusive and being sure that we're using this whatever you want to call it, teachable moment or otherwise, to the its greatest advantage.
I think the one last thing that I wanted to say is that even though we aren't seeing dramatic intervention effects, these data are still consistently showing better than background spontaneous quit rates.
Right.
And
These are
so there's
individuals who are
something
motivated to quit.
Yeah,
right?
there's
More than
something there, and
right.
there's opportunity to leverage. So.
Yeah. So this is Bob Smith, American Cancer Society. I've been really impressed with the complexity, but also the sort of mission-oriented sets of strategies that are attempting to sort of deliver these benefits, and especially the degree to which you've got to be patient with patients, and offer these the opportunity to quit in a relentless way. And that's partly where things really do seem to fall apart. And you look in some of the primary care settings that we're working in right now, it's like, oh yeah, smoking cessation, we've got to start doing that again, because they're hardly doing it at all. And I'm just wondering if there's an approach that might sort of reboot this, where you can better communicate how important all these elements are, perhaps address the reimbursement thing, which seems to be an enormously important issue, because you can say we are going to actually pay for this now. But it also impresses me that if we do a better job of this before people are eligible for screening, they might not be eligible for screening at all, because they would quit much earlier. In other words, this could reboot smoking cessation in the non-eligible, current smokers as well. And I'm just wondering if the whole smoking cessation in the context of lung cancer can't revitalize a systematic, evidence-based approach to smoking cessation that becomes an expectation, that there's a way to do this in almost every setting. If the settings are too small to afford to be able to support a department that you can refer to, then what could they do? I mean, what kind of guidance might be provided? Do you all have any ideas about this? Because we don't really see the various strategies that naturally fit wherever you are.
So I'll start. I really like the direction of your question, because it suggests an approach to thinking about all of our screening settings as living laboratories, where we collaborate together to identify best practices, and we use what we know is about practice innovation. And I think whether you're a carrot person or a stick person, I think one of the things we do have as an opportunity with the guidelines and with the registry is to think about auditing, measuring, performance feedback, and really incentivizing screening sites to with carrots, with reimbursement. So the federal guidelines actually have given guidelines for coverage about what is a reimbursable tobacco cessation guideline. These are woefully underutilized, but at least this is only a year old, that we actually have under affordable care. These are reimbursable. There have been federal guidelines that have identified what constitutes a definition of a covered benefit under cessation. So I think there are unique opportunities now to put that into place. And I think one of the things would help at a point I want to sort of get out there is, I think one of the advantages or one of the things that we could do to facilitate this is to come up with a standard set of process and outcomes measures that would be included in registry. So we could actually begin to see beyond the checkbox what's actually being delivered so that we can ensure that we're providing high quality tobacco treatment in high quality screening centers. So I think there are opportunities here, both by policy and by guidelines that are unique and capitalizable.
When I work with providers and talking about tobacco treatment implementation in settings, I often start with the discussion of the question of what do you do in your daily life that you technically fail at 90 to 95% of the time that you continue doing. And I use that as an example of how it can be difficult to sustain tobacco treatment efforts with populations, particularly in my area of the country, that have very high rates and very extended rates of tobacco treatment. And using sort of that empathic approach, similar to motivational interviewing, to kind of meet them a little bit more where they are and allow them to express their frustrations about, you know, I try and I just get beaten down and depressed about how little effect I'm having, and sort of talking about some of that work and trying to engage them in understanding that, yeah, that you're not unique in that experience of having difficulties achieving the kind of outcomes that you'd like to, but that doesn't reduce the importance of sustaining it. I don't know if that really works at all, but they seem to appreciate the empathy and the discussion about that.
Right. Well, I mean, the data do show, and I've just noticed this, recent to this literature, is how unhelpful it is to then also say, and how helpful is it to then be belittled and then told that you'll do it when you're ready and you could do it if you wanted to. Or that, the average physician who never smoked or, doesn't know what an addiction is like.
One quick comment.
Yeah, we can have one more question. Yeah.
So that's exactly the point I wanted to bring up. Jamie, I think you're the one that said that a lot of people of that generation were smokers. They were in a totally different environment. It was more the norm than anything else. And a lot of the physicians don't really understand that. I just did a focus group around with people around lung cancer screening. And one of the things that they all told me was, hey, it was normal for us to smoke. Everybody smoked. People would smoke in the kitchen having breakfast. So it was a different generation and a generational approach. And if we can address that and say, yeah, we understand it was different, et cetera, and do the empathetic approach and say, we don't, it was normal at that time, so now things have changed. So how do we move forward and not blame you, but understand what you went through, understand the environment you grew up in, and then move forward to help you quit?
Thank you. I wanted to add to that and also finish the last comment and doing motivational interviewing training with primary care physicians around this area. I think that the biggest thing that's a takeaway often for them is understanding where a patient's at and that not all patients require action. So in our world as psychologists with behavior change, we think of cognitions, thoughts, and behaviors. And the cognitions meaning if a patient isn't ready to quit, you don't do anything. You say to them, I want you to think about it. I want you to read a little bit about this, and we'll discuss this later. And then if a patient's ready, you're actually going to give a referral. And I think it's really hard for physicians not to give that referral. And that's when they get burnt out, what Jamie is saying. And so I think teaching simple interventions really would help facilitate that work.
All right, I want to thank everyone for a fantastic first day. I don't have a lot of wrap up other than to encourage all of you to join us for the reception on the third floor, I believe. So please join us, and I look forward to more conversations. And come back tomorrow. Come back tomorrow. Thank you.